Pleasure to be here, and I enjoyed yesterday evening. Very good food and also very good wine. I'm still coping with it.
It was the first time.
Yes, first time so much wine.
We hope for the second time.
I'm wondering how do I advance the slides? Is there a button? This one. Okay, perfect. Good. This is my ICU. It's quite an old hospital. We have about 38 ICU beds, a medical surgical burn unit. And many of the patients are like this. We call it a tattoo man or tattoo woman syndrome. They are unconscious because of overdose. So the hospital is a bit in a poor neighborhood and sometimes with very speaking tattoos. This was in a man. We have 1,500 admissions, about 5,000 ventilator days, 10,000 ICU days. So this is the hospital as it used to be. This was round wards, and there was an inner and outer circle of patients. And this was the old days. Quite cozy in the night. You had some bats flying in the high ceilings. Very interesting. Just to show you that in life things do change. And this is myself here, which was 17 years ago when I was in training in the hospital. Please don't laugh too much. And some things don't change and are from all places, all times. And I was a witness of a marriage of a patient with COPD, tracheostomy. So we disconnected him from the ventilator and the patient said, yes. And then we had to put him back on the ventilator because he was going into carbonarcosis. So this is the hospital I work. It's quite vivid. I have to disclose some possible conflicts of interest. The biggest conflict being that I was the co-founder of an illustrious society, which is called the World Society on Abdominal Compartment Syndrome. This happened in beautiful Noosa, and it was December 2004. Normally, the weather should be excellent, but it was raining, so that's why we drank a lot of Australian wine. And while we were drinking the wine, we got the idea, let's make a World Society on Abdominal Compartment Syndrome. So just to give you an idea, if you want to make your own society, you pick a good spot, like here in Athens, you drink a lot of wine, 4 people, and you go on. So what I would like to do with you today is to give a brief introduction, when to measure abdominal pressure, how can we prevent, because that's the main focus with the medical management, a little bit on surgical management. Are there any surgeons in the room? Surgeons? No surgeons? Okay, so one surgeon. We can speak freely, 2 surgeons. Okay, because the biggest issue, if you have a patient with a high abdominal pressure, is to get a surgeon convinced to open the abdomen. It's true. I don't know why, but sometimes the surgeons don't like to open these abdomens. But we'll see more about that later. So, why do you need to know this? Well, maybe you don't need to know this and it's nothing of any importance. You may like it because some think of abdominal pressure as a sexy, hot topic. Luciano Gattinoni always talk about this as a sexy subject. Maybe I don't know either, but I think it may change the clinical practice and the way we're treating patients. Mercury is a good threshold. So, not only us, but also other investigators around the world are interested. And if you do a PubMed search on abdominal pressure, you find an exponential increase on the data published. The summary of this is that about 1 in 4 of ICU patients will have a high pressure. 5% will have full-blown abdominal compartment syndrome, which is a high pressure above 20 with new onset of organ failure. Mortality is quite high, so you must measure the pressure in order to know what is happening, because clinical examination is not enough. So why? We've all seen patients in the ICU with a lot of fluids, and they're all swollen up like the French Michelin mannequin. And question is, did we measure the abdominal pressure? We've all seen patients given massive fluid, swollen up, and suddenly pops up a CVVH machine and they're going into renal failure. But did we measure the abdominal pressure? And of course, we've all seen patients with massive fluid, renal failure, multiple organ failure, and then they die. But what was the abdominal pressure? Maybe we could have done something to prevent that from happening. So management is important. And the management in the ICU is based on 4 principles. Of course, you must have a low index of suspicion to monitor the abdominal pressure. We can do something to prevent abdominal hypertension. the medical management, and then there's always the knife of the surgeon in case all things went wrong. So when do we measure abdominal pressure? This would be based on the presence of 2 or more risk factors. And basically it's a low compliance of the abdominal wall, which you see after massive fluid loading in obese patients, burn patients, if there is gastroparesis, if there is some free fluid, ascites. But most often it's related to sepsis, capillary leak, and the combination of acidosis, hypothermia, coagulopathy has been referred to as the deadly triad, which may lead to ongoing blood loss, giving more fluids, more dilution, and then enhancing a vicious cycle. So it is important to prevent abdominal hypertension from happening. Because when we are giving fluids to our patients, we will create intestinal edema, especially if there is a capillary leak, visceral swelling, increased abdominal pressure, compression of mesenteric means, and venous hypertension, which will need us to give more fluid. So we have a vicious cycle, and we must avoid massive fluid loading. We have to keep the lungs dry, but we have to keep the liver from being well perfused. If we give too much fluids, you may end up with peripheral edema, but also with edema of all the organs, and organ function will be endangered. My friend Michael Pinsky, I must respectfully disagree with his statement when he says that peripheral edema is only of cosmetic concern, because it is not. Whenever there is a first insult, whether it's a sepsis, a trauma, or burns, we will give fluids to the patient, and the patient will enter what we know of as the distributive phase of shock, which is the ebb phase. Intravascularly, the patient is empty, so he needs fluids. We need an early goal-directed treatment, and fluid balance must be positive. The ebb phase can be dangerous if the patient is too empty. The second hit comes from the ischemia reperfusion with a distant organ dysfunction. If the patient keeps fluids on board and ends up with a positive cumulative fluid balance, this is a biomarker, and the treatment should be conservative with a 0 fluid balance, and usually this happens around day 2, day 3. Then 2 things can happen. Either the surgeon performed very well the source control, we're giving the antibiotics, the patient resolves shock and goes now into the flow phase of shock, but many patients will be in an unresolved state of shock, and this will result in what I would suggest the third head being a global increased permeability syndrome, giving edema into the lungs, the bowel, the kidney, the extremities, the brain. If we keep on giving fluid to the patient, at this stage fluids may become toxic, and we should have a late goal fluid removal with a negative fluid balance. Flow phase can be hazardous. So I would suggest 3 phases. In the first, we monitor hemodynamics, then organ function, abdominal pressure there, maybe ICG, PDR. Fluids from life-saving become toxic. Early adequate goal-directed, late conservative fluid management, and late goal-directed fluid removal with a fluid balance from positive to negative, and that is very important. With the injury and the inflammation, we have increased permeability, and this will lead to ascites formation, increased abdominal pressure. But the ascites, if it's kept within the patient, it's rich of cytokines, it will further enhance permeability and inflammation. So this inflammation and permeability will sequester fluids in the third space and the second space, leading to what I would call toxic accumulation of limbs, ascites, and interstitial edema. Toxic because of the presence of cytokines, which will enhance the permeability. With this ongoing systemic inflammation, the patient will end up with distant organ injury, acute lung injury, intestinal injury, kidney and hepatic injury, or multiple organ dysfunction syndrome, as the patients that I showed you initially who die. So we must do definitely something about this and prevent this from happening. That's why with the World Society, and you can find the algorithms on the website, we developed a 5 pathway approach, and in each pathway a 3-step approach, and I would like to briefly go over this with you. First is we need to optimize the perfusion. The first step is, of course, we need to use the right fluids. We must prevent fluids from accumulating, so early aggressive we must be. And this is a study in burns where they used hypertonic lactated saline, and you see you need to give less fluids, same urine output, and lower intra-abdominal pressure. So maybe hypertonic fluids may help us in not having too high intra-abdominal pressures. We must monitor in analogy to cerebral perfusion pressure, abdominal perfusion pressure, and studies have shown with row curve analysis that the best threshold would be an APP above 60 millimeters of mercury. Again, with hypertonic solutions, we have higher perfusion pressures. So what about next step is the hemodynamic monitoring. If you look at CVP, many studies show that if you increase abdominal pressure, you will see an increase in the CVP. And the reason is because of the transmission via the diaphragm from the increased pressure in the abdomen to the thoracic space. And you can easily calculate at the bedside, if you have the increase in abdominal pressure, the increase in CVP, what I would call the abdominal thoracic index of transmission. In this case, it's 55%. And you can simulate this at the bedside if you would apply a pressure on the abdomen. On average, if you look at animal and human data, it's about 50%. So if the nurse tells me the CVP is 16, abdominal pressure is 16, then the transmural CVP will be 16 minus half of 16 is about 8. And in the acute phase, this may help us to guide resuscitation. Volumetric indices, on the contrary, are lower in conditions of increased abdominal pressure because of a diminished venous return. So we have opposite forces when we look at preload, whether it's barometric or volumetric, so we should use volumetric preload indicators. What about fluid responsiveness? Well, some data, mostly animal studies, show that if you would increase abdominal pressure up to 18, this will result in a doubling of the SVV, PPV, the usual functional hemodynamic parameters that we are aware of. If you would live in France, you would be very much familiar with the active leg raising, but we want to look at passive leg raising. Thing is that if you have a high abdominal pressure and you would put the legs up, you will not see an increased venous return. So maybe if abdominal pressure is increased, you may go for the Trendelenburg position. Of course, you must prevent ventilator aspiration and not to do this in increased ICP. But it's important that we realize these effects. So we must at all times maintain a good perfusion pressure, and this should be done initially with fluids, but very soon with the instauration of vasopressors. So next step is to improve the compliance of the abdominal wall. We can do that by optimizing sedation, analgesia. In this study, looking at epidural analgesia shows an increase in the compliance of the abdominal wall, a decrease in abdominal pressure, and an increase in abdominal perfusion pressure. So this may be a way to go. If there are any constrictive bandages, like a Velcro belt, old surgeons in Brussels use the ventre or tight closures. These should be removed if the patient is hemodynamically unstable. In case of burns, if there are circular burns, we must perform abdominal but also thoracic escharotomies to improve the compliance of the abdominal wall. We recently did a review on prone positioning. Of course, if you put the patient prone and you don't allow the abdomen to hang freely, this will increase intra-abdominal pressure. So when proning the patient, be sure to do it the right way and to use the right mattress. This study showed that if you use not a good mattress, this is a foam mattress versus an air cushion mattress. If you use the foam mattress in the proning, you will have an increased intra-abdominal pressure. What about head of bed positioning? We do this to avoid ventilator-associated pneumonia, but putting the patient from supine to head of bed may increase intra-abdominal pressure, and we must be aware of that. We saw a case of a fatal abdominal compartment syndrome who was on non-invasive ventilation. The physiotherapist put the patient upright and he collapsed because of a sudden increase in intra-abdominal pressure. On average, head of bed results in a 5 to 15 millimeters of mercury increase. So maybe if you have a high pressure in the abdomen and difficulties with ventilating, this is the right position to put the patient in. Of course, the effects on abdominal pressure will be dependent on body anthropomorphy. As we all know, men are usually apple-shaped, as you can see here, and they will have a metabolic syndrome with a high abdominal pressure. And we also know that women are usually more pear-like shaped, but ladies, I can assure you it's better to have a fat ass than a big belly. Sorry for this sexistic remark. Okay, so we must of course monitor depth of sedation, and If all this does not work, we can use neuromuscular blockers. By doing so, we can decrease intra-abdominal pressure, and this could be a life-saving action. In this patient fighting on the ventilator, you have a high abdominal pressure, you curarize it, and you see abdominal pressure coming down and end-tidal CO2 coming down. There's a lot of analogy between the abdomen and the brain when it comes to monitoring and treatment. This is a high abdominal pressure, a high end-tidal CO2 with a cisatracurium continuous infusion. You see end-tidal CO2 coming down, abdominal perfusion pressure better, and intra-abdominal pressure under control. Fluid administration is very important. So we must be initially early aggressive, but we must aim for a 0 to negative fluid balance. And survivors most oftenly have a cumulative fluid balance, which is in equilibrium, and maybe the late conservative part in the treatment may be more important, so to avoid fluid overloading. So we must find the balance between what I told you, the ebb phase and the flow phase of shock. Can we mobilize excessive fluids with diuretics? Some studies show a slight decrease in intra-abdominal pressure. If you have a negative fluid balance, you will see a decrease in intra-abdominal pressure, but the data is not so big. We could use albumin, hypertonic albumin, by increasing oncotic forces. This will result in a negative fluid balance and will result in an increase in PF ratio, and this may help in patients with intra-abdominal hypertension. We use in our hospital the PAL treatment, which is a combination of a PEEP set to counteract the effects of increased intra-abdominal pressure. Then we put the albumin and then the Lasix, and you see you have, of course, a higher albumin level, you have a lower fluid balance, and the extravascular lung water together with intra-abdominal pressure may come down. Other possibilities are the use of hemodialysis and CVVH, small series showing a decrease in intra-abdominal pressure when you get rid of the excess fluids. And interesting to see is that now also beyond the ICU literature, in cardiac papers, nephrology papers, people allude to the fact of increased abdominal pressure and the deleterious impact on organ function. So what about intra-abdominal fluids? I think it's important to perform an ultrasound in any distended abdomen or a high intra-abdominal pressure. You may find lots of different sources of increased intra-abdominal fluids. And sometimes it's very nice. It's like a small worm floating there into the abdomen. So it's a fascinating world. Just do the ultrasound in your patient with distended abdomens. What about renal resistive index? We've heard about transcranial Doppler. You could do the same principle if you put a Doppler on the kidneys, and you could measure renal resistive index, which is a peak velocity systolic minus diastolic divided by the systole. And normally it's below 0.7. As you can see, in a high intra-abdominal pressure, this was a big study. There is no diastolic flow and a high resistive index. And they found a correlation. The higher the abdominal pressure, the higher the resistive index. And this may guide our resuscitation in this patient. So if there is any free intra-abdominal fluid, we may like to drain it, as they did in the Middle Ages in patients probably with cirrhosis and probably after heavy drinking of these kinds of fluids. We do this ultrasound guided. Here you can see the cavity draining the ascites, and after drainage we can see a drop in the intra-abdominal pressure, but also a drop in the central venous pressure, because both pressures are linked via the intrathoracic pressure. After the ultrasound, we can perform a CT scan. If there are any drainable collections, we should go for it, and we can do this CT guided. Sometimes it's necessary to call for the surgeon and to consider surgical evacuation. Last part is the evacuation of intraluminal fluids. Again, we must insert nasogastric tubes, gastroprokinetics, especially the gastric dilatation or maybe in combined or Gilvey syndrome. We put gastric tubes, and you can sometimes evacuate reasonable amounts by that. We again perform ultrasound, and you can see there is normal peristalsis. So to identify the possibility to start or increase enteral nutrition, again, ultrasound is an interesting tool. If you see this image on the abdominal ultrasound, which sounds like an S, the bowel is sleeping. If you see the S, it's asleep, and you should not increase enteral nutrition. If patients are feeding intolerant, intra-abdominal pressure is higher, and during the first week, feeding intolerant patients have a higher intra-abdominal pressure. Rectal enemas are also important. Colonoprokinetics can be given. We use a stool protocol to keep fluids, to keep the stool fluid-like and to have a continuous drainage of the colon. Sometimes we may need colonic endoscopic decompression. So this was the medical management, and if all this fails, there is always the possibility to go for the surgeon, and this is the only definite way to decrease intra-abdominal pressure. Of course, this results in an open abdomen. Most oftenly it happens at 3 o'clock in the morning, you're on call, so some things you must or must not do. This is Professor Sugru, one of the co-founders. He's asleep and his resident goes to open the abdomen. First thing, you stay in bed and let the resident do the job. When you start working as an intensivist, and this is Professor Mike Cheatham who is organizing the next Congress, you have to ask the surgeon, there are 2 surgeons here, to take the oath. Whenever the intensivist calls you to open the abdomen, you must come immediately. Avoid this. Avoid this. If you use a new technique, be prepared that you have seen it before and you know how to use it. You could start some prayers, but this may probably not help. Be a man, get the job done. Don't do this. This is a Sissi incision. This is a designer open abdomen. This is a Jean-Paul Gaultier. This is not the way to do it. It should go from symphysis to xiphoid. And stay alert. Don't trust everything you read or that people may tell you. If you put together the literature on decompression, you can see that after decompression, abdominal pressure sometimes is in the range of compartment syndrome and sometimes in the range of abdominal hypertension. But putting all the data together, you can see a drop in the pressure and you can see an increase in urine output, although in the 2 largest studies, there was no effect on renal function, maybe because it was too late. Overall mortality is still high at around 50%. So, I would like to conclude. If we want to understand if the patient is at risk for compartment syndrome, well, 1 in 3, 1 in 2 will develop at some stage a pressure above 12. And we know that is important when we look at CVP or when you want to ventilate the patient. 1 in 15, 1 in 20, about 5% have full-blown compartment syndrome, which is a high pressure and new onset organ failure, and this also happens in medical patients. Should you monitor it? Well, it's directly related to organ failure and mortality. It has an impact on other monitoring capabilities. Again, CVP, filling, ventilation, recruitment, opening the lungs is important. Clinical exam is inaccurate, so you must measure the pressure. Can you do something about it? Well, you must be aware, recognize it,